Dr. Nabeeha Karadawi, who is consultant medical oncologist at Letterkenny University Hospital, and Dr. Jimmy William, who is Haematology-SDHI at University of Waterford. They're going to share their experiences and training in these fields. Before we get started, I'd just like to ask you to mute your microphones. And if you have any comments or questions that you want to ask, if you type them down in the chat box, and we can go through them at the end of each presentation. So without any further delay, Dr. Karadawi, if you'd like to kick off the meeting, please. Thanks.
Perfect. Can I just share my your primary medical qualification need to be recognized, which I think everyone have that. Specialist training in oncology abroad, that's mainly for people who are trained in Europe. But I think in Ireland, mainly you need to work in university hospitals. As far as I remember, as per the Irish Medical Council, it's 4 years of training in university hospitals, and you need to be trained by a different consultant in each year. So even if you're doing, for example, 2 years in James's, you need care and definitely research and audit and teaching and leadership. So the courses in the RCPI, you need to complete it before you apply for the Irish Medical Council. And they're very adamant about it. There's no joke about it. I know the waiting list is huge. You have to prepare yourself in advance. So maybe from the first year, start looking for the longer course and just try to finish them as soon as you can. Once you finish with that, you'll be at least clear from the RCPI courses, which is at the same time, the courses are quite beneficial for you to give you an insight about leadership and how can you teach your colleagues and how can you do your research and audit. So it's definitely something that we'll be suggesting to do it if you're thinking about medical oncology from now. Your curriculum will be aligned with medical oncology mainly. So we have a special logbook, and I think part of the things that you need to be a bit nosy and just ask one of your colleagues who are working as SBR to get them their logbook, and you can just sneak and just see what they have in their logbook mainly, what required for them in their oncology curriculum. For example, you need to report, I remember, as far as I can remember, at the time that I did it, around 20 cases of neutropenic sepsis that you saw, and you have to write it. You won't write any details of the patient, but you just tell the story of what happened, what did you do. Again, cord compression, all the oncology emergencies that you have to know how to deal with it and write it in a proper way for the assessor to see that you're able to do that, because this logbook will be looked at by different consultant and will be assessed then through that, which is a logbook clinical experience. So I think it's a cord compression, it's neutropenic sepsis, and what else? Other emergencies, all the emergencies in medical oncology anyway. You have to write it. I think it's around 20 cases per year that you have to write it. And then there's 5 extra cases that if you see anything unusual or anything interesting you need to write it all in your logbook. You need to show that you're doing some teaching. So for your colleagues, for example, for the 6th year, 5th year medical student, or supervision, for example, for doing any procedure. We're not asked a lot about procedures in medical oncology, but just the common thing, for example, aesthetic dab, the simple thing. I know people tend to start not doing it now because it just it's more specialist, but it is something that I think you need to put it back in your mind. Also to keep your CVDs all the time, just you have to be adamant about doing the RCPI professional developmental program every year and keeping track of that. If you have any publication, that's an add-on, and it's a great chance for you whenever you're going to any hospital to show your interest to consultants and just tell them that you're interested in doing some research. It's even good in your CV in the future. It definitely will be helping you to progress in the future. One of the tricks that I think you need to and all the consultants in medical oncology are really, really great. You have to have a very good relation with all your consultants. When I'm saying that doesn't mean that you have to be paying them for everything, but you will need them one day. Even at your level as a consultant, you will be taking the phone and just taking the mobile and just ringing them. Oh, this case is this and this. What do I need to do for that? It is something that, and they can ask you at the same time. It's a great backward and forward experience. So definitely don't get scared of the consultants and just keep a good relation with them. They will be very supporting for you if they feel that you're very interested in doing medical oncology. At the same time, don't show false kind of interest. If you're not interested, like it will appear at the end. So just be careful about these things. And I think once you're in the track, you will know. There is a great consultant in medical oncology. They're really, really good. They're very supportive. Can be a little bit scary from far away, but if you go near them, they're really, really good. So definitely keep a very, very good relation with them. So for the application, you need your application package, which you ring the medical council, you ask them for a package of medical oncology. They will send you kind of an email, I think, with the kind of many documents, as I said, like early on, like the cases. It's something equivalent to the SPR training. It's mainly just mapping the experience to medical oncology, and then you have to fill all this logbook with your details. I'm not sure if it's by email now or still like we have to do it submitted kind of manually before, but I'm not sure if it's the same now. But you have to fill it, and then you have to get assessed by, I think, 5 of your consultants. They will be kind of filling a form for you that need to be signed by them in a closed envelope. So you will not be allowed to look at the envelope and just see, because it's completely like it's their assessment. And then you submit this logbook to the Irish Medical Council and wait for there's a fee. I think it was, around 4,000 before. I'm not sure how much is it now, but there is a fee that to be registered as a medical oncologist. So you pay the fee and then you'll wait for the decision and registration. And usually they're quite kind of, it can take a bit of time, but at the same time, they're quite, I think, now with having not a lot of medical oncology consultants, I think they're trying to process things a little bit quicker. So if you're thinking about it, I think it's definitely just starting out your logbook and just start like thinking about submitting your papers. Challenges usually that you will be facing, like for example, if you're missing a few cases. So like the best thing, I think, if you're starting the first year, over the 4 years, just keep track of these cases. Regardless if you're thinking about going through the alternative pathway, if you're thinking about doing something else, I think just keep track of your documentation all the time, especially the cases, because at the 4th year, you will be forgetting what did you do in the 1st year. And you can't just repeat the same cases all the time. I know financial acceptance, for example, will be the same, but still there is a small variation that will make a difference. So definitely keep track of everything. The different training standards, like for example, working in different hospitals without naming anything, might give you a different opinion and might reflect kind of differently in your assessment. Definitely look for hospitals that they have, for example, people who are looking after training in general, and like it's very like it's very easy process. You can just talk to anyone, consultant, and definitely they will give you advice what you need to do for regarding this. Exams, if you would like to do like the courses for the RCPI, at the same time, all the 4 years will not be counted for you unless you finish your MRCP exam. So you definitely need to clear your tests first, your MRCP or MRCP UK, before you're going ahead with applying for the CSD for medical council, because they want like the years will not be counted for you unless you finish unless you have your MRCP UK or Irish exam. And then just kind of the long processing time, as I said, like I don't think it's the same long wait as before, but at the same time, just kind of be prepared that you can prepare these things in advance. So I think the best thing, just prepare early. I know it's hard sometimes just kind of to decide about doing something. And then once you start, for example, oncology, and it's like, oh, looks very depressing, I can't do that. There's nothing about no going back for everything, that you can definitely revise yourself and just kind of see what you would like to do. But I think it's a good thing that you just kind of start early, think about it, and then take your time to prepare it. And if you don't want it, you can just kind of change it to another side. Medical oncology is part of medicine, so you definitely will be open for all other medical branches. Still, when you're doing medical oncology, we're seeing a lot of medical cases. So it's not a one way that, oh, you can't go. It's definitely something that you need to think of. And if you're not able to do it, you can just kind of change your mind then. As I said, good relation with the SBRs is really, really good. I hope, Jimmy, you don't mind that. But I think if you're having kind of a good relation with them, usually you can get the logbook, you can get kind of a copy, at least, of the things that they're requiring to do every year, and that will keep you in track, like with the medical oncology kind of changes. One thing I forgot to say earlier on, medical oncology is quite evolving kind of branch. So even if you, like for example, in medicine, if you miss around 4 months, it's fine. You'll come back and you'll find the same MI treatment, the same like diabetes treatment. It's not like the changes are there, but it's not huge. And people tend to know about it a lot because it's a general medicine. For oncology, things are changing quite fast now. And you just have to keep track of the conferences and all the updates. Like even if you miss about 2 weeks, you'll come back and you'll find, oh, there's a new drug that had been advertised now. Saying this is not scaring you, still the medical oncology medication is quite narrow. It's just kind of big families. And I think if you know the basics of it, you will get used to it. You will get scared the first year, the second year, you won't know anything about, oh, I don't know anything about the treatment that they're talking about. But after 2 years, you'll definitely will be picking up in everything. You will know the emergencies, you'll know the side effect if you're interested in doing things in the right way. It's a great branch to work in. Like it's really, really nice. And I think me and Tamer will try to pull as much people as we can that we can just do medical oncology with us because it's really one of like I don't think I regret for a second that doing medical oncology. So it's definitely something that very, very interesting. And if you have interest, feel free to contact any one of us. I think myself, Tamer, Yasar, there's a lot of people that are around that you can just kind of contact and just ask if you have any questions. Same thing, leadership, audit work, just try to keep track on the RCPI kind of requirement as much as you can and keep an organized electronic portfolio. I'm very bad with organization. I usually kind of mess up my stuff. My laptop now is completely in a mess now because I can't keep track of things. And that's really, really bad habit. So it's great that you can start doing that when you're young, not at my age. So as a conclusion, it's a valuable route for experienced oncologists. It required a lot of kind of preparation, documentation, but definitely it's doable. It's not something that you're not able to do. And it will definitely open a lot of channels for you for the future if you'd like to work as a consultant level as medical oncology consultant. No year that you will be working as medicine, as a surgeon, if you'd like to come for oncology, you will be like it will be a loss for you because oncology, including radiology, surgery, medicine, you will see a lot of things. And as much as you're exposed to a lot of things in medicine, apart from pediatrics and even obs and gynae, like we have some, but it's a great branch that you want, like if you're doing any other years, it still will be quite valuable for you and your experience. So that's all my talk. I'm so sorry. I don't think I'm being prepared very well because it's very short notice, but I hope you got some of the information that I'm saying there. And as I said, like I have I can just send my email there and my mobile. And if anyone would like to be kind of contacting me, I don't have any problem.
Perfect. Thank you so much, Dr. Karadawi. That was very informative. And I think you shared a lot of great insights about the discipline and how to go on about training. I think we have one question from Dr. Amna Sharif. She's asking about regarding accreditation. So regarding staying at one hospital 2 years, would it be calculated as 1 year in training or 2 in the alternative pathway?
So if you're doing it in a university hospital and there's 2 training, so like for example, you work with Tamer as a consultant and Nabeeha as a consultant for the 2nd year, that would be counted as 2 years. But if you're doing with Tamer for the 2 years, it will be counted as only 1 year. So just these small things that you need to be careful about. And just, I think the best thing, maybe speak with a consultant at the start of your training, and they will be guiding you which way of doing it. Because like they will be delighted for anyone to kind of to join oncology. So it's just definitely something that you need to discuss with the oncologist, like the first time that you're thinking about doing the alternative pathway.
Perfect. And I think thanks, Amna. I think the other point that you brought that's really important is about the documentation, because I think this is a big hassle at the end, like trying to get kind of a backlog of all the cases that you went through to get accreditation. So I think it's very important to be aware to start inputting in that log, see what are actually subtitles, the headings that you need to fill out and map it out according to the SPR training scheme and their prospectus, and then kind of input it on a weekly basis, I would say, so you don't have that headache of going back and to log all the cases, the different complications and the procedures as well.
It is, and it will, at the same time, it will just keep your mind very fresh about doing these things. So it is definitely, I totally agree with you, Tamer.
Yeah, no, that is great. I think the other important points that you mentioned is in terms of keeping good working relationships. I think that is really important, particularly because those consultants are going to be your colleagues in the future, but they are the ones who sign you off. So do not think that you are that the interview is kind of just the interview at the HST interview or whatever interview for your job, like a registrar job. The interview actually starts from the first day you work or walk onto the ward, and the consultants are assessing you. So assessing you on a daily basis. They want to see, are you competent? Can you work as part of a team? And do you go the extra mile as well? So just think of that as well for all our trainees. So put the effort in, and hopefully you'll be rewarded. I'm not sure. Do you have anything more to add in terms of medical oncology before we?
I think you covered everything there, Tamer. I think it's definitely, as you said, like as I said early on, at the level of being a consultant, still you will be meeting these consultants in conferences and kind of meetings. If you need a case that you're stuck with, you will be ringing them. So, and like no one is having anything against you. Like all the consultants, actually, they're really, really good. They're mainly looking at patients. Things are changing now. Like, for example, before at my start of my training, we'd just be thinking, oh, treat patient, treat. Things are changing now a lot with quality of life and think about patient as a kind of a full, and just think about the whole story, taking just the basics of proper history exams and then do the investigation. People are rushing to do the exams, like the investigations a lot now. And I think that pissed the consultant a little because you just feel like, oh, it's your machine, like, oh, patient come with, for example, short of breath, or you're ordering CTPA. You have to think. And I think that will make kind of the consultant think about how competent you are and what clinical skills that you have. So you definitely need to be thinking, same as when you have been in the medical school, that starting with inspection, palpation, oncology is working like this. And I think things are changing now with the resources and trying to cut kind of the amount of investigation that we're doing. Like as Tamer is saying, the minute that you're coming to the day services or to the ward, you will be assessed by the consultant if you're taking the right decision, if you're rushing to do just investigation. So keep all that in track, not to scare you, just be yourself. I think if it's just something that you'll click. If you like it, you will know how to do it, how to deal with it. Yeah, and that's it.
We have, thank you very much. We just have one more question from Dr. Abdulatif, and he's asking about MRCPI and to get through to medical oncology through BST. Abdulatif, I'm not sure if I totally understand your question. Do you want maybe to even open your mic and ask it? Like, I'm not Abdulatif. Is your question about doing medical oncology as part of BST or as part of HST? I do not get your question.
I actually forgot about mentioning the PST early on, the basics specialist, like in medicine, basic training program. I'm aware that I think medical council need the PST before going through the alternative pathway. Yeah. Though saying this, I know a few people who did not do the PST and still were able to manage to go through the alternative pathway. I did my PST years and years back. So I'm not sure what's the rule now, but I'm aware there is few people who went into alternative pathway and got their CST certified without doing the PST. So it is something that I think you might just need to check with the medical council, what requirement, because they're just changing the requirements from time to time, if that's your question, Abdulatif.
Yeah. Abdulatif, the other thing is you don't have to, like, if you didn't do medical oncology in your BST, you don't have to do it to apply for HST, but it does help. If you do it as part of your BST, or the other option is to do like a year standalone. Usually that is required as a registrar, just to be sure that you enjoy the field and that's the career that you're looking for. And again, for the consultants to know you as well. So perfect. Abdulatif, hopefully that answers your question. If not, just type in the chat box and we'll get back to it. So Dr. Karadawi, thank you so much for that. Now we're going to move on to hematology, and we have Dr. Jimmy William, who's the SPR in Waterford, and is going to share his experiences in training in hematology.
Hi, thank you for this opportunity, and thank you for hosting me there. Thank you, Dr. Nabeeha Karadawi, for your excellent talk. And is the screen shared there now? Can you hear me?
Yeah, we can see the screen and we can hear you fine.
Oh, brilliant. So, Grant, so basically, as I said, my name is Jimmy. I'm one of the SPRs now in Waterford. I'm in my first year, and hope you will get a few bits from this talk. So I'm going to be into more details, just because, like, I know it's kind of difficult to go through all the bits and pieces in hematology, especially that a lot of us didn't get through kind of any kind of training during in Sudan. And it's kind of a bit different here. So what we will cover in this session is kind of hematology service in Ireland, who should apply, challenges, CV tips, HSE application, HS interview, and then we'll be answering question if any. Sorry, it will be a lot, but I think it will be relevant to all of you guys. So we'll start in with hematology, just to get you an idea on the how huge is the service of hematology, and is as well as oncology they share a lot. So so the number of meetings we have, the number of societies that we have. So you have the Hematology Association of Ireland, Ireland Multiple Myeloma Society, Lymphoma Forum Ireland, and CLL Alliance. Those are the ones in Ireland only. And then you go for EHA, European Hematology Association, the International Myeloma World Group, ASCO, which shared with Oncology, BSH, and then ISDH for thrombosis, ESMO, ISMEL in Lugano for lymphoma, and obviously the American Society of Hematology. So these are all societies that and kind of meetings that we attend. It just shows you how many like how broad hematology is, from malignant, benign, coag, and sharing a lot as well with oncology. So in hematology service, what do we do basically? So we're looking at the benign, malignant, coag, transfusion, and a bit of an academic. So the benign, you're looking at your sicklers, your anemias, autoimmune hemolytic anemias, ITP, things like that. And then you have your malignant bits, so your lymphoma, leukemias, myelomas, coag bits. So there are two different bits there. So the general coag, which it's not in all the centers that you do kind of, you have like a specific coag service, like in the Mater and Galway and Cork, for example, they have a dedicated coag consultant, as well as in Vincent, for example, and other hospitals. But like, for example, now in Waterford, we don't have a coag per se. So each consultant covers coag. And then there is another bit of a specific coag, and that will be kind of the hemophilia patients. And in Ireland, those are kind of following up either in the National Coag Centre in Dublin, as in James's, or in Cork. And obviously in pediatrics, you're going through Crumlin. Also, there's a transfusion. So that's an international, the Irish Blood Transfusion Service, and that's in Cork or in Dublin. Also, there is an academic bit that you can do. So you can get to become a consultant, and then you can get like some time off of the clinical work doing some research. And same like, for example, Prof. Dwyer back in Galway had like was off work for 5 years, and he's doing kind of, he got a research grant, and he's done a lot of research in kind of CAR T therapy and NK cells. And he came back to work after that, and it was a huge thing basically in Galway. Also, you basically cover your heme lab and your blood bank as well. That's part of your job. So you basically look after as well hemovigilance in certain extent. So you have your inpatients, your day ward procedures. The procedures we do is basically obviously bone marrow biopsies and lumbar puncture with intrathecal chemotherapy. And as well, part of our day-to-day kind of work will be kind of covering the lab. So you'll be reporting blood film, aspirates, and in some hospitals as the trephines as well. And obviously you have your clinics. In Ireland, there are like 9 big hospitals, the main hubs. So like James's, Beaumont, Cork, Galway, Waterford, and then you have your smaller hospitals like Cavan, Navan, for example, or Mayo, where they kind of facilitate some of the chemotherapies, like azacitidine, for example, or DARA even. Also, there's another bit of hematology, which is like with the maternity bit, which is like in the Rotunda or Coombs, for example, there is a dedicated hematology consultant there. And you basically look into, for example, pregnant patients having a background of hemophilia and how to kind of optimize their care before treatment. On those pregnant, like for example, if a pregnant lady got like an autoimmune hemolytic anemia or kind of an ITP, you also follow these as well. As I said, again, you have your IBTS and NCCP. So you have kind of in general, kind of 4 big branches in hematology: your benign, your malignant, and coagulant transfusion. And just to add a bit, that in most of the not a must, but the kind of the trend that's going now to the hospitals is basically in one specialty. They like, let's say with malignant, there will be a consultant who's more into lymphomas, and there will be one consultant looking after the leukemias and another one for the myelomas, for example. So that's the trend now. So which is a good thing, basically, especially with Dr. Karadawi said earlier, there's a lot of advancements in hem-onc basically therapies. So you wouldn't be able to keep track with all of these medications, especially in hematology. So subspecialties is a huge thing. Another part of the hematology service would be the MDTs. So you'll have in any hospital, you have your radiology and pathology kind of meetings looking at the scans, PET scans, CTs, MRIs, as well as at the biopsies with the lymph node or even the bone marrow trephines in some hospitals, looking into the new patients to make a proper diagnosis, make sure we're not missing anything, kind of thing. So it is a very busy job. You will have lifelong on-calls, unfortunately. But the good thing is that you will rotate in most of the hospitals, especially in the bigger ones, you will be rotating. So one consultant will be covering for a month, for example, the inpatients, and then goes to cover the consults, and another month you cover the lab, something like that, basically, which is very good. You have 2 exams during the training, the FRC Pass Part 1, which usually candidates do in the 2nd year probably, and then the second part will be basically on around the 4th or the 5th year. It's very advanced in the sense that you need to read a lot, keep up to date as much as possible. And because there'll be new drugs, new guidelines, new categorized stratifications of patients, whether they're high risk or standard risk, basically. So a lot of advancements, which is very interesting, basically. Who should apply? I don't really go with this graph, but I think it's somehow a way to think about it. So you don't have to be a nerd, you don't have to be kind of having great grades or whatsoever to go into hematology. But I think I couldn't find the hematologist. The nearest thing was pathology. But I think it's you need to, I think if you like kind of, you don't like routine, basically. If you want to kind of go between doing procedures, between doing a bit of benign, a bit of malignant, looking to the lab, looking into clinical, as in covering the inpatients. If you like that kind of blend, then hematology is your go-to. Okay. As well as one of the things is that you will be, you have this kind of relation with your patients, in the sense that your lymphoma patients, you're going to follow them up for more than 10 years, basically. So my advice, I put this there, that think twice before looking into hematology. The reason I said that, a lot of is not unheard of that people do go into hematology and then they go to a GP scheme, or they go to other specialty, do radiology, for example, or something. Because of the intensity of hematology, it is a busy service, but a lot, this is not the majority of the people. I'm just saying this because it is, you need to make sure that this is the right job for you. So I'll be more keen. I've seen SPRs that went from an SHO job to an SPR immediate, like directly, and it was tough for them. Okay, so do a standalone rear reg, and I'll tell you again about it later. It will be very helpful, and it will solidify your commitment. It will solidify your experience and exposure, and make you sure, but kind of basically that, oh, this is the specialty that I'm looking for. It's nice as well if you're like so into medicine and you hate kind of weird shifts. So it's kind of a grand thing. So and as I said again, if you like a mix between clinical lab research and procedures, hematology is your go-to specialty. And you have no issues kind of being stuck with big patients for several years, and subscribing to several journals to keep on up to date with your with the newer guidelines, basically. Definitely, my advice will be work in bigger centers. You get more exposure, more patients, more cohort of patients. Like even in bigger hospitals, I worked in my experience, for example, in the year I did in Galway, for example, it didn't see a lot of CNS lymphomas where I went to the matter, and then they're like, oh, like few CNS lymphomas. And the same as well, different cohort now in Waterford. So different areas, but bigger hospital will basically expose you to different aspects of hematology as well. In the matter, it was a lot good. Like the coag is a huge thing, and it's a very nice. You get a good teaching basically in coag, especially. You need to be doing your posters and oral presentations and look into the meeting. I'll come to that in a bit as well. The main thing with hematology, you need to have a lab experience, and it's good to have it in, and you have basically better exposure if you did it in bigger hospitals. Mater, Galway, Cork, Beaumont, James's, of course, and Limerick as well. I don't want to I can't say the whole hospitals in the country, but there are a lot of big hospitals, and so it's a good opportunity for all of the people, basically. Even better if you can do trifines. Not all of the hospitals do report the trifines. In Mater we did, and there is Drogheda and there is Tullamore as well with Dr. Pereira. Experience as a reg, as I said earlier, for a year at least, and basically you need to be known to the big guns, and in the sense of you need to go to your meetings, you need to let them know that you're interested in hematology. Definitely go into the poster. If there's one comment from my interview, is that that I was told about afterwards by the consultant, is that my consistency in presenting, as even I couldn't get into oral presentations, but my consistency in presenting posters in all of the conferences is one of the things that you actually say in your interview, and I'll come to that in a bit as well. Challenges for candidates. It's a very competitive, for some reason hematology now is very competitive, although it's very busy. I don't know, to be honest, but it's maybe the advancement is one thing, maybe the blend of clinical research, maybe, but it's obviously interested. If you choose it, it's really grand. And then teaching. Try to go to places where you can get teaching, and there are a few hospitals where you can get really good teaching. Your like standalone job. Morphology is another bit of challenging thing, because not all of it's a busy job, so not all of the consultants will be able to sit with you, kind of go through morphology. But once you find some, you will come to the hospital, and you don't want to be like, if you did go to the consultant and basically say, look, I would really appreciate if you can just give me 10 minutes every week or every other week with morphology, that will basically mean a huge thing to you, and you will learn a lot basically from it. And we all did that, and it's only the basics, and then you build up on it. So get the basics and then you build up on it. Gray zones cases, and this is, you will get more exposure to it in the when you're a consultant more so. Go to the meetings, because and a lot of people don't get involved in the meetings. So so my advice, definitely go, even if you don't have a poster, try to go if you have a poster, that even be a great thing. So have a solid CV, and we'll come to that in a bit. So your CV, when you're applying, it's not like a mandatory thing to kind of apply or get your CV into the application, but there is a way of uploading it in the application itself. And I think it's worth it to actually upload it. And actually, the consultants go through it, and they did go through mine and other of my colleagues in the last interview. Basically, just don't make it a huge, like, don't do like 10 pages. Okay, so 5 to 6 pages is more than enough for applying for the HST. Go through your personal information and a small kind of goal highlight. Look, in the goals and the highlight, you can be going like very simple, like 2 lines, basically, as in I'm an enthusiastic or doctor. I'm looking for get training in the HST and becoming a consultant hematologist in Ireland, with building upon my experience. And you can write basically building upon my 5 years of medical training, 3 of which is a hematology focused training. That will be kind of a catchy line in the beginning. Then you put your credentials, and then put your awards and distinction. And please, when you put in your awards and distinction, in Sudan, I know we don't have a lot unless you get prizes. A bit different here in Ireland. There are different prizes and different awards, especially when you're in university or even afterwards. But there's a lot as well. If you don't say, oh, my distinction during my bachelor bit is not gonna add anything. No, put those, actually. Put that you got a distinction, you've graduated with oral over distinction, or put that you got like a prize in forensics or in community medicine. It doesn't give you extra points in the criteria itself, but it will let them know that you have been an achiever since you're in the university. Okay, and you have been committed. Okay, no one will get a prize or award if it's not committed. So these are the things that you need to play around. Post, obviously, put your posts in chronological order. And basically, if you've done hematology for 1 or 2 years, don't put the same thing. Like, basically, you say the name of the hospital, how many years you stayed in that hospital, and then what you learned in that hospital. And obviously, if don't put the same things, basically put different things. If one hospital you learn how to manage kind of stem cell transplants, then the other hospital you need to be like, oh, I've gained more exposure in coac, for example. Then you put your audits and QIPs. And basically, you don't have to put just the name of it, in the hospital you've done it, and the year you've done it. You don't have to write a lot about it. Just the name and the year and the hospital you've done it in, as well as then you go your publications. For your publications, if you have loads of publications, then you can go for first author and co-author. If it's just you have like 1 or 2, just put them as publications, and that's it. Management experience is a huge thing as well. A lot of my colleagues that have come through who are applying, whether to the BSc or to the HSE, they don't put into consideration that actually covering or coordinating medical convoys back in Sudan matter. It does matter. A lot of people here did not get to be exposed to become kind of a medical clinical director to an emergency. Put that, okay? It is important. It is relevant, okay? And they know it's a different kind of experience in other hospitals. Obviously, you cannot become a clinical director here while you're kind of an SHO or a registrar, but they understand that. They understand the difference here, okay? And you can tell them more about it in the interview, which we're gonna kind of talk about in a bit anyways. So put that in as well. If you've been a medical director, or you've been like a coordinator for medical convoys back in Sudan, if you have been, obviously you can put the rotas and things like that you've been in charge of the rotas, but everyone is going to put that. You need to be different, okay? Teaching experience is another thing that you need to put. All of us who've been in Sudan, we've done at one stage teaching, so put that. And if you can do teaching here, there are loads of teaching opportunities here in Ireland, so make use of them in any hospital, okay? And you actually can get an award. There's like the best NCHD teacher, for example, in Galway. There is as well as like the best kind of the best NCHD teacher of the year. There's best NCHD Reg of the year, for example. things like that in some hospitals. These are the award. These are, you can do the teaching and you can get awards about it, and it's very relevant. And get a letter from the university, like from UCC or Galway University, that you can ask them basically to give you a reference or a letter basically. So I've done that, for example, myself, and I know a few of my colleagues did, and it will give you extra points, okay? And they like people being involved in teaching. The other thing is the courses. Please don't put the BLS and ALS. Everyone have done that, okay? You've been your BST, for example, so you've definitely done your BLS and ACLS. If you're looking into hematology, there are morphology courses, there are coag courses. You can go into these, and these will be more relevant. If you done stuff back home, like I think in Sudan there was like fundamental critical care support, and there was like ultrasound and statistical courses. Put those; they are relevant, even if you've done them back home. And don't say, "Oh, it doesn't count." It doesn't matter if it counts or not. It's how you sell it in your interview. So put it in your CV. It's a relevant thing. It tells them that you've been involved before in courses and you're doing your job. You're ticking all the boxes, not just because you're ticking the boxes. It's because you're actually into the job. You love what you're doing. Lastly, you can put your competencies. So put your don't put your IV cannula. You can put like, and unless you're doing kind of ultrasound guided IVs, you can put that you do like LPs, bone marrows, trifines, you're reporting bone marrows, you're reporting aspirates, doing fluorocentesis, fundoscopy, otoscopies. Skin biopsy is a relevant thing in hematology as well. And then obviously, lastly, but not least, you put your references. And this is how you go through your CV and write it. HSD application itself. So it's the same always in every other specialty. So you go your qualifications, publications, clinical experience, leadership, teaching. So the teaching will go from down to upwards. So the teaching, either you have kind of, you're doing a master's in medical education, or you've done kind of a teaching, or you've been involved in teaching, for example, in Ireland or back home. So this is the relevance of doing teachings, teaching. So please, if you've done one in Sudan, get a reference and just let them know that you've done this. It does count, okay? And please get involved, try to get involved in the teaching early on. All of what I've said earlier, just not to forget this point, this is a lot of things to prepare for. So use your BST to prepare for your HST. You know, at this stage, it is a bit challenging sometimes for us who are coming from outside Ireland to get into HST, and everyone would be able, they're a bit tougher with us or whatever. But we have strong points. We've done teaching, we've done a lot of management, we've done a lot of clinical experience. Use all of these actually, and it does, and they appreciate this experience, and they appreciate this is what you're bringing to Ireland, and you're going to build up upon it. Okay, so that's something. So you use your BST for your HST, and another thing that you can do in your BST is basically, if you're not, let's say if you're going to go for oncology, for example, make sure that you basically, if you can rotate into radiation oncology, do a bit of palliative, do a bit of gastro. That will be very relevant, and it will help you a lot in your medical. And you can say it basically in your interview. Basically, say I've kind of through my BST, I've looked forward for specialties and switched to specialties that will help me in my oncology year. And the same for hematology. If you're looking for hematology, definitely do a renal rotation, do infectious diseases. They will be very relevant. If you can do palliative, that will be as well great. So do kind of rotations that will help you in your HST. Okay, and this is something you can say in the interview as well. Leadership, I'm not going to go into it. There's a lot of leadership opportunities here in Ireland. NCHD, everyone goes into the NCHD. You need to be different, do something different. So for example, there's RCPI trainee site representatives. And this is a very good one. It's a very prestigious, classy one. You can do it. You can go, if you're into, for example, hematology, you can be involved, can be the NCHD representative for the blood transfusion committee, and each hospital has that, and it's very relevant. So be involved in committees. Drug and therapeutic is another one. Be involved with committees that will actually matter to the specialty you are looking for. clinical practice, obviously, look, if you're looking for hematology, you need to go into bigger hospitals. So that's one thing. So do whatever clinical experience, mention whatever experience you did back home in Sudan, for example, or even here. But here you need to mention, if you kind of say, like, when you start your interview, basically say, my name is, for example, my name is Jimmy William. I'm currently a hematology registrar in the Mater or in Vincent or in Cork. They know these are big hospitals. So you've probably looked at your inpatients, you've done your day ward rotations, you've done the lab, and you've reported blood films and aspirates, and you're happy, and you're more capable more than capable to do your procedures, your bone marrows and intrathecal chemotherapies. So they know that, okay? And the consultants know you as well. Publications and audits, as I said earlier, and then your proficiency undergraduate. There's just one tip there: try to get your centile ranking early on. Okay, it's one of the things that messes a lot of, even if you're like, I had a problem before, but that was in the BST, that although I was kind of ranked top in my batch, but the way they do it in Sudan or in my university was a bit different. So you need just basically I contacted them. Basically, they told me, get a letter that says that you're kind of a top of the top 20% of 10% of the batch, and that count gave me extra points, from 6 points to 16 points. So it doesn't matter. These are the things. If you get, obviously, any teaching awards and higher degrees will count as well. So your masters or PhDs, if you did any, that will be great. The interview itself, you will have your CV, your research and audit, career planning, clinical question, and then hematology service development. I'll go quick through them. Sorry, I'm talking a lot today, but bear with me. For example, for your CV, everyone told me it's actually 1 minute, but it's not. In the HST, it's not a 1 minute. You have 2 to 3 minutes, okay? And no one will cut you. If it's in 2 to 3 minutes, no one will cut you in kind of the interview. They want to know you, because this is the only interview that you will have for the next 5 years. You're going to be a consultant once you finish the HST. So they want to know as much. They've seen your CV, they've seen your application, and they did talk to the consultants you've worked before. Okay, Ireland is not a big country; it's a small country. So any consultant, especially in hematology and oncology departments, for example, everyone knows each other. Okay, so it's a close community. So try to so they know you, but they want actually to talk to you and basically know as much as possible. So you have 2 to 3 minutes. Use that as much as possible. Tell them a bit about your experience in Sudan, but that should not be more than 20 seconds. And basically say, I graduated this year and I have done 5 years of, like, what example, GP training back home. And then I relocated to Ireland looking for a higher specialty training, or looking to be trained in hematology, for example. If you did a hematology rotation back home, mention that. Like, like, for example, I've done a blood transfusion. I've worked like 1 year in the blood transfusion service in STAC. I've mentioned that because it's relevant to my interview. So it was a 20-second kind of line that I've worked. I graduated in 2013, for example, and I've done 5 years of the GP training, and I've worked as a GP, for example, and one of which I've done a blood transfusion service job for 1 year, and then I relocated to Ireland looking for a higher specialty training. Then you go basically and say, on the interview, you need to go into CAM. Basically, it's your clinical experience, your accreditation, your management skills, and publication. In the sense of, as I said, my clinical experience, I started like in Sudan in 2013, and then I relocated to Ireland. And in Ireland, I've done my BST, and you can add here the bit that I've actually targeted or kind of suited my BST training towards hematology by doing whatever rotations. And the most relevant bit will be the last job you're doing. So if you basically say, and currently I'm a hematology registrar in the Mater of Vincent, and I'm looking after the inpatients day ward, and I'm doing chemo, I'm chemo prescribing, I'm doing my procedures as well, and as well as reporting blood film aspirates and trifine. They know you're working the Vincent, but you need to say it, basically, lay it out. After that, you need to go for the A is your accreditation, and basically you go say, on my accreditations, I have done my MRCPI, I've done a master's degree and so and so, and as well as you can add then, though this is basically your accreditation, then you go basically for your teaching experience, and basically say, from a teaching perspective, I have 2 years of clinical experience in two different universities back home, as well as I've tutored students in Galway University Hospital, or UCC, for example. And if you got an award, for example, you added there's like, and I was actually awarded the best NCHD teacher for that period. It's a relevant thing, say it there. Then you go to your management skills, and basically from management skill perspective, you say, for example, I was the RCPI trainee site representative, and I was well involved in the quality improvement projects during my time, for example, in blood transfusion committee as being the NCHD representative, and my quality improvement project involved 1, 2, and 3. You sum it up in few words, and that's it. And basically say, last but not least, I've done 12 papers, I've published 12 papers, including meta-analysis. You can sum it up basically as much as possible, but tell them you've done, for example, a meta-analysis, you've done a case report. It doesn't matter if you've done a systemic review, or if a systematic review, or you've done a case report. It means that you're interested in research. That's what they want to know. Okay, and basically say that I have 12 like or 10 or 5 publications in prestigious or reputable journals, or whatever you can say, but you need to sum it up. I know I'm talking a bit fast, but there is a lot I wanted to cover, just because I know it's a bit tricky, especially in the interview bit. When you go, and basically at the last bit, when you end up those 2 to 3 minutes, please don't just stop talking, and basically sum it up. Basically, you can say, in essence, with 2 years of clinical experience, a strong academic portfolio with my teaching and accreditations, I'm looking forward to get more exposure during the HST years and training in, for example, in other subspecialties, because you've been probably worked in hematology, so you'd be like, I want to get more exposure in stem cell transplant or coag or whatsoever you can name it, and with the ultimate goal of becoming a consultant, a hematologist in Ireland. And that's how you finish your 2 or 3. It's a 2 to 3 minutes. Make sure you say all your experience, sum it up, say the important bits, don't miss anything as much as possible. And that's why you need to prepare for your interview at least 2 months before, at least. That will be my advice. What else that's there? So choose your boards. Basically, you can use AI, actually, ChatGPT or Claude, in organizing those bits as much as possible. It's a very helpful tool as well. Have an idea about the scheme. So basically, you just have like a 30-second line about the hematology, and basically you can say it's very unlikely they ask this question now, but if they did, that you can say basically it's a blend of clinical and laboratory exposure as expected, with 5 years of a scheme, including 1 year out of the program year that we can do a fellowship or research. During the 4 year or 5 years, we have mandatory rotations, including coag, transfusion, allogenic stem cell transplant, and pediatrics. They need to know that you know the program. Okay, you need to do a bit of work about that. For clinical questions, they're going to be very straightforward question. If you've done hematology, you're going to answer them. It's likely going to be like a neutropenic sepsis, and the reason why they ask an easy question or someone that is because they don't want you to answer the question itself. It doesn't matter to them. They know if you've been a hematology registrar, you probably know how to manage your neutropenic sepsis, but it's how you word it, in the sense of You have like a 15 years old or like 20 years old male who has AML, who was brought in by neutropenic sepsis, for example, or febrile temperature neutropenia, whatever. Don't just say, oh, I'll start with my A, B, C, D, E. No, they don't want to hear that, actually. You need to say, basically, thank you for this important question. And during my, this is a very relevant question, and I've been encountered with these cases during my period as a registrar in the matter or in Vincent. And then you answer your question after that. So every question they kind of ask you, whether it's a research, an audit, whatever, you need to basically pick pull down a balloon, as the Irish say. So basically say, get something from your experience. If they ask you about research, what research you've done, don't just say, I've done 1, 2, and 3. No, and basically you need to say, as I mentioned before, I have 12 or 10 publications, including meta-analysis, and I would like to speak about 2 of them, 1 and 2. You tell them that you've done. You don't tell, because if you answer them, you're going to answer that you've done 1 research or 2. Whereas if you added this introduction, you can tell them that you've actually done 10 researches or publications, and then you go on to explaining, because you can do, you probably haven't done all the 10 publications in hematology. Probably in general medicine, when you're doing a BSc or back home in Sudan, so you probably haven't done it they're not interested to know that you've done research in diabetes, for example, but they're happy to know that you've done research. So you say an introduction about the publications you've done, and then you answer their question. The last bit is that the hematology service development, you need to do your kind of digging, in the sense of that you need to know the challenges in hematology, in the sense that we know, for example, elderly population is a huge thing in Ireland, and you need to throw in kind of statistics, in the sense of we know that in Ireland in 2028, there will be 1 million above the age of 65, which puts loads not only in a hematology in general, but we're looking into a geriatric hematology service. So we need to look into implementing that in our service, which is not something that I have seen in my rotations in 1, 2, 3 hospitals. So that's how you do your hospital. And I just gave an example here about the audit experience. And basically what you need to say, like when they ask me about audits, I was like, since 2019, I've completed 5 audits, 3 of which focus in hematology. The results of these audits were presented in renowned hematology conferences, including HI and BSH. Additionally, as part of a quality improvement project at SUH Sligo, I played a key role in developing a local guidelines to improve the accurate diagnosis and management of iron deficiency anemia. That's how you word it. You can obviously go around it, but this is in general how you need to word it. The interview itself, I'm almost done, guys. Sorry, apologies about that. I know we're running a bit late there. So it's going to be in the RCPI. It's going to be into face-to-face, and it's going to be upstairs, basically in the RCPI building. The panel will be 12 consultants. 2 will interview you, basically, and this is where the time comes that you will really appreciate if you know 1 or 2 faces, okay, familiar faces, because it will give you a peace of mind at that stage, and it will calm you a bit. It's about 10 to 15 minutes. CV, you go into 2 minutes, then utilize this in the name, current post, quick view of how you ended in Ireland, then camp, as I mentioned earlier. You conclude with the summary, as I said, and then don't say it's subspecialty, in the sense that don't say I want to be a coag consultant. Don't say that, okay? Because in the whole panel, there will be probably 1 coag consultant, but you put it in general. Say that I would like to be exposed to coagulation or more work in hemophilias, but don't say that I want to become a coag consultant. Eye contact is important, and be confident, take a sip of water. It does make a difference. Do not repeat yourself, use it. It's 10 minutes, use it wisely, okay? 1 question will always throw you out. My question was, why do you think in Ireland drugs are not reimbursed? And that's where your statistics comes in. And my answer, for example, was that the government cannot afford to pay all of these drugs, because, for example, we know in the CAR-T we're paying when it actually started, we were paying almost 800,000 per patient, and that's including obviously the hospital stay, the ICU admission, the drugs, etc., etc. And also in Ireland, we're paying only, I think, 6% of the GDP goes into the research and innovative therapies and chemo therapies, whereas in Germany, for example, it's like 20%. In the UK, it's 12%. You need to know statistics so you can throw it on. So they know that you know what the specialty is, you know the challenges, you know you're not actually preparing to become an SPR, you're actually preparing to become a consultant. And that's the importance of preparing. Always pull up a balloon in any question they ask. Just don't answer it directly. Make a small introduction of 5 seconds. And the more you rehearse this, the more it's going to be more smooth, and it's going to flow very smoothly, basically. Always say things that as to why they should give you the job and why you are the perfect candidate. They are ticking the boxes while you answer their questions. Do not say things you haven't done. Don't say, I'm looking for the training to do my FRC pass. That's just, you're basically trying to get points that you don't deserve, basically, okay? Say that you know there are these exams and you will be taking them, but don't put it in the way that, oh, I've done my MRCPI and I've done masters and I'm looking for a PhD. Don't say that, okay? And the most important is the introduction and the ending of each CV. So dig the statistics. All of this is going to be repetition to what I've said. Mention something innovative, that because part of the challenges, you need to say, you can say the age. Don't throw one thing, you can throw one or two things there. So you need to be innovative. Don't, like, for example, they will be asking you what's kind of a newer medication or an article that you came across. I remember when I was speaking to my consultants, they were like, never say CAR T, because last year everyone came into the interview spoke about CAR T. Okay, so be innovative, find something new. Okay, in the sense of, you can not speak of CAR T, you can speak of biospecifics, for example, or a newer kind of, you can speak of next generation sequencing and how it's kind of now our hematology diagnosis and stratification of patients is actually have evolved a lot after the NGS, something like that. Know your HST program. Improvise in the sense of, if you have a patient, if you have a degree, for example, you've done your master's in diabetes, for example, don't be kind of embarrassed or kind of shy to say it. It is a master degree. It helps you to, basically, you can round in a sense of saying that I've done, for example, a master degree in diabetes, and at that stage I was doing it while I was a GP, and if anything, it helped me. It had a robust research program which helped me to build up a solid research background and knowledge that helped me actually to publish few papers. And we know the challenges we face with our patients who are getting prednisolone, for example, which is a backbone of a lot of chemotherapies. So now you've blended what you've done into the hematology service, okay? Prepare for answer something like what and why in hematology, recent advancements, weaknesses. In a weakness, don't say, for example, I love work too much. Don't say that, okay? You can say basically something like, during my SHO job, I was so in kind of I would like to do everything for my patients on my own. And then when I actually upgraded into a reg, I understood the importance of the team dynamics, and it's always kind of a divide and conquer situation, especially in a busy hematology service. Something like that will work. Your audits, your publications, you need to know them in and out. For SPR lab role, you need to know about your day-to-day jobs, and that's your kind of doing your reporting your blood films, aspirate and refines, as well as know about quality control, your INAB, your NEQUIS and ISO, and those basically are just the accreditation for the lab. So INAB, for example, is the Irish National Accreditation Board. So basically it certifies that this lab is actually accredited to do these tests 1 or 2 and 3. And know, for example, they need to do like a quality control, for example, the coag once a week, for example, and for the flow, for example, every month, I think. It differs from a hospital to another. So you need to actually go to the lab and ask them about these. Heme challenges, as I mentioned, the cases are straightforward, as in the sense of everyone knows how to treat neutropenic sepsis or an APML, for example, but what they want you to say basically, or what they want to hear is basically starting smoothly by saying, thank you for this important question. I came across, it's a very relevant question in the sense that we've all encountered an APML during our call. And I remember a case that I've encountered while I was doing I was a reg in Galway University Hospital, and how I managed this patient. You go then through, I've looked at the blood film, contacted my consultant, I looked to make sure that the patient is well, look at the ABCE. That's how you do it, basically. So they know the steps, but you've made an introduction about it. So keep in mind that they're interviewing like 15 candidates per that day, okay? So they might forget that you've done a job, for example, or in Galway, or you've done actually 2 reg years instead of 1, okay? So that's very relevant. Recent study, as I said, know your lab job. The machines actually are important. You know what kind of machines you use for FBC. Is it Sysmex X1000 or XN1000? These are relevant stuff as well. My questions were basically go through your CV, talk about 2 researches you've done. The clinical questions were like a blood transfusion reaction, white blood cell of more than 100 on call. What do you do? Challenges in hematology, plan in the next 10 years, lab experience to date. And that was not a big question. They were literally saying, your lab experience to date. I was like, yeah, I've done 3 years. I've done 3 months in the matter, and I've done a few more back in Sligo. And I've reported blood films, trifines, aspirates, and I've gained a lot of experience because I've actually done a job in Sligo and then in the matter. So this is how. So basically, those are the kind of questions. Advice going forward: know your statistics, waiting time in Ireland, health GDP, kind of slum care plan, population in Ireland, things like that. Do a mock with your SPRs and consultant. It's a very important thing. And each one will tell you something. Don't say, oh, I've done 2 mocks with 2 SPRs. No, it's not enough, okay? Each one will tell you something different, okay? I've went to 4 SPRs and they all told me like, oh, that's grand. You prepared very well to it. And then went to the 5th one and she was like, Jimmy, what the hell are you doing? Basically, there is a lot of things that you need to change in this. And actually, I had to repeat the whole process again. And in fairness, that was the best advice given to me. And a lot of changes I've made. And so basically, the message just to sit with few consultants, few SPRs as much as you could. It will benefit a lot. I was going to talk about medical oncology, but I think Dr. Nabeeha have done more than this than me, to be honest. So I think that's it for me. Sorry, I talked a lot there, but I'm happy for any questions if there are any.
No, thank you a lot, Dr. William. That was very comprehensive, a lot of very great and important points there. Thank you for the presentation. And I really like the slides you had with all kind of the detailed criteria and points within the HSD application and an interview. I think it's something that people can work on just to see if there's any gaps in their CV. They can start working on them from now. We have one question from Mooley John, and he's asking any advice for a newcomer as a hematology registrar. In particular, what are the expectations for you in order to be a competent candidate? And what are the things that make you jump off the page and make you leave good impression during your daily work?
So basically, look, it is very challenging to come into the first job as a reg, but if you have good experience, it will be easy job for you. I think the most challenging bit in Ireland is the MDTs, getting your head around the MDTs, getting your head that your patient is not, you're just not managing the clinical bits. You're managing their home stay, their OT, their physio, their psych, their those bits and pieces, medical social work, getting your head around these and knowing that actually you can finish your chemo as much as you want, but they're not going to leave the hospital if these things were not like have been dealt with even before. Like, for example, once a patient comes in with acute leukemia, for example, you need to make sure that you spoke with your medical social work, because they need an emergency medical card to get those chemotherapies in. No one would be able to afford that. That's one. The other thing is that if you're treating, for example, an elderly patient, once they're like in the middle of the cycle and they're on, like they have another maybe 1 or 2 weeks, one of the things that you need to say, basically mention that, look, I think this guy needs a bit of physio, a bit of OT to push him up, so we'll be able to discharge him. Or he needs a home help, or he needs the home help package, the whole thing. Or I think this guy would benefit from a bit of rehab. So these bits are more challenging, and the consultants are more interested at getting their patient discharged because of the waiting list. Like, I think in Galway, for example, they had a 15 waiting, like 15 waiting all the time. There's always 100 and like 15, and those would be like Hodgkin's lymphoma, nothing something like easy. Like it would be like Hodgkin's lymphoma waiting, or an acute leukemia, for example, something like that. So NDTs is one. The other thing would be definitely try to speak with one of the regis here to give you kind of an update, or kind of highlights of how the department functions, and just get your head around the medications we use, the chemotherapies, because as well that's a bit of challenging. So I know you can go to the NCCP and get all the chemotherapies you want, but the tricky part is, like when you use, for example, gemcitabine, you need to be you make sure that you are looking for kind of thrombosis, or if you're using how we're managing, for example, our ICANS on CRSs, when you are using bispecifics, for example, when to kind of dose reduce when you're using kind of that are epoch in patients, or things like that. Those like few tricks, because each country will have its own chemotherapy and its own regimens. That would be my own advice.
Very good. Next question is from Dr. Shahab Hasid, and she's asking where to look for courses in hematology, and where to start at looking at studying about morphology, books, learning material in general.
That's an excellent question, because actually it will take you a bit of time to get to know these bits. But here, a summary. For morphology, you have Blood Academy. It's a very good place to start in. Just Google Blood Academy. It has loads of courses in morphology, coag, and etc. For morphology as well, if you have visa to the UK, there is Barbara Baines. She's kind of the best morphologist in the whole world. She does morphology courses, 2-day courses in the UK. Other learning sites, you can use HemBase. It's a brilliant website, summarizes all of the it's kind of almost 90% of the time up to date. So HemBase is another one. And if you're a textbook lover, then kind of Essentials Hematology for Hofbrand is one of the brilliant textbooks. So here's your learning, basically, go-to places.
Thank you. Okay, any questions from participants?
Can I just add one thing to the brilliant lecture that Jimmy did? It's amazing. Something that I think I have been in that stage that you get so scared about the HST, so you won't even volunteer going to it, and you just kind of hear from people, oh, you won't be able to do it. I think if Jimmy is able to do it, everyone else is able to do it. He's amazing. He's reporting you everything that you need to do. You just need to work and prepare well. I remember I went to one interview of the HST, and mainly we did the mock interview, and the consultant was asking me about, okay, what did you do in Sudan? And I was kind of like, oh, embarrassed about saying that, oh, I worked in like teaching, like these things that actually Irish people think that it's valuable for them, because we don't have the same training that they did here. We don't have the same availability of like investigations and these things, and that will like actually make our clinical senses really, really good. I think also these people are kind of having a great clinical sense, and at the same time they have to kind of how to save resources because of the fact that we have been coming from a very like less developed country. So like don't feel ashamed of yourself and just be yourself, be real. You're able to do it. Don't listen to anyone who's telling you you're not able to do it. That's part of my mistake that I did at that time. And I think just with my circumstances, I wasn't able to go again for it. But at the same time, it's the first line for you. Go for the HSC. Try to get it. It's easy. You were well able to do it. You're definitely, I think there's plenty of examples in front of you that they paired well. They worked hard for their things and they love what they're doing. So just do it and go with the pathway. Ask people. Asking is not a shame. I'm quite sure like any one of us, like for example, Jimmy, I know they're very busy. Everyone is very busy, but at the same time, they can spare a bit of time and just tell you about the tricks and the tips, even if you miss something from the lectures today. But just don't feel that you're not able to do it. That's part of the things that Sudanese people were telling us before. Oh, HSC, oh, forget about it. No one will be able to get it. It's very, very competitive. You won't be able to do it. You are able to do it. Just go for it.
That's great advice, Nabeeha. And I think, especially that I think with most programs, there are more places available now as well, which is great compared to 10, 15 years ago. We have last two questions, and then I think we might wrap up. We have another question from Dr. Shahid Hasib, who is asking, which hospitals give standalone registrar experience in the lab? I think that's directed to you, William.
Excellent question, actually, because not all of the hospital will give you that, especially will be more the SPRs doing the lab job. But I think Mater is one of the hospitals you'll get a very good, busy morphology, but you come out of it really good with morphology. Dr. Sumong is one of the really good, like all of the consultants in fairness, but Dr. Mong loves a bit of a teaching morphology bit. So that's a good place. Tullamore is another one if you can get through as well. These are the two hospitals. Beaumont, they do a lot. Beaumont, actually, they do a morphology, even if you haven't covered the lab, which I think you do actually cover the lab, but they have like a huge, like a big microscope with 12 lenses. So there is a weekly teaching there. So I think, so a lot of hospitals, in fairness, but like in the sense of not all of the hospitals, but I'll give you basically three to go to. Mater, Vincent, Beaumont, these are the top three. And then in the sense of these are definite kind of, they will give you an opportunity in the lab.
That's great advice. And last question from Dr. Sarah. Thank you. Any advice about how to get involved in audits outside Ireland or to collaborate? And I think that'll be open to both of you, Dr. Karadawi and Dr. William.
Do you want, Dr. Karadawi, you want to go first, or?
Yeah, I think our CPI actually are quite like, they're quite handy, and like they're very kind of, if you just email them and just ask them if you'd like to collaborate with them, they're very good actually in supporting something from outside. So definitely be in touch with them and just ask them what they can offer. Thanks, Jimmy.
Thank you. Definitely same, exactly as Dr. Karadawi said. And the other bit as well, if you can get involved here with audits, you can do it in your own. Like Sudan, I think, is the most, of all the countries, actually, the amount of research audits that you actually can do in Sudan is unbelievable. And the cases are just like, and that's how, as Dr. Karadawi said earlier, our clinical sense is based, because here you see early aortic stenosis, for example. In Sudan, you see the end stage, and you're able, like in a blink of an eye, to assess a patient, say this guy is severe aortic stenosis, and that's it. Same goes, this patient is not responding to antibiotics. I don't think he's responding to antibiotics. Clinically, he doesn't look like it. We're really good at making those decisions. And so yeah, you can do an audit in Sudan. That's fine. And I think the tricky part, not the tricky, but most of the challenge that we see is that, oh, I don't know how to do an audit. there you can go, for example, in Dove Press. It's one of the publishers, the journals. Dove Press has a clinical audit journal. You can look actually at the audits they have done, and it gives you an idea how to do an audit. It's a very simple thing. There are audits that you can finish in 3 days, and there are audits that it can take 3 months basically to finish. So you have all the extremes basically, and I think you have way better chance in Sudan to do, like, there's a very good chance in Sudan to do very, very good audits and research.
That's great. Yeah, so I think at this stage, I will say I'd like to really express my thanks to Dr. Karadawi and Dr. William for their very insightful presentations. I'd like to thank the team from the SGI for their immense effort in putting this marathon series together. Thank you all the participants, and as you can see, the advice from Dr. William and Dr. Karadawi is plan ahead, and it does take some effort, but there is nothing stopping you. So do go for these HST applications, and best of luck with them. Best wishes with your applications, and بالتوفيق inshallah. Thank you.
Thanks very much. Have a lovely evening.
Thank you.
Bye.
Thank you, Dr. William. Thanks.